Hello, everyone, and welcome back. As a reminder, you're listening to the Insights edition of the NCS podcast. As a reminder, Insights is a teaching podcast geared to residents and non-neurologists and non-neurointensivists for sort of a broad overview of how to approach neurocritically ill patients. As a reminder, all of the content that we feature comes from the on-call chapters on the NCS website. We really invite you to check those out because they have a much more comprehensive look than what we're able to provide in the podcast. We are also so grateful for our sponsors, Biogen and Cerebell, and now a word for one of our sponsors.
Founded in 1978, Biogen is a leading global biotechnology company that has pioneered multiple breakthrough innovations, including a broad portfolio of medicines to treat multiple sclerosis, the first approved treatment for spinal muscular atrophy, and 2 co-developed treatments to address a defining pathology of Alzheimer's disease. Biogen is advancing a pipeline of potential novel therapies across neurology, neuropsychiatry, specialized immunology, and rare diseases, and remains acutely focused on its purpose of serving humanity through science while advancing a healthier, more sustainable, and equitable world.
All right. Hi, guys. Hi, Casey. This is Salia, Neuromuscular pharmacist at Hopkins. Glad to be here again. Today, we're going to talk about neuromuscular emergencies in this big umbrella of neurological emergencies. So, Casey, I know that these patients can be really complicated, especially for a non-neurologist, which is me. So when you see these patients, how do you usually assess them first? Can you walk us through maybe the first few steps of how you would go about assessing these patients?
Yeah, absolutely. These patients are not as common as some of the other patients that we've talked about. So, I think up to this point, we've covered acute ischemic stroke and ICH and status, which are all much more common than neuromuscular emergencies, which I do think creates a little bit more apprehension around how do you assess these patients. The same is true for basically all emergencies that you want to start by assessing their A, B, and Cs. What's different about these patients is so many other patients in neurocritical care need protection and ventilation because of altered mental status. Our neuromuscular patients actually have a totally different pathology that's going to lead them to needing intubation. And that is that they have weakness of the really complicated musculature that controls breathing. So if you think about breathing, it's actually kind of a pretty complex and really amazing process that starts with, respiration pattern generators in the brainstem, and then involves all of our muscles of breathing, namely the diaphragm. So the diaphragm is really what is the driver of inhalation and exhalation, but it's also supported by some of our accessory muscles, which become more important as that diaphragmatic weakness takes over. And so these patients are really at high risk of having hypercarbic respiratory failure because they cannot maintain that ventilation drive. But in addition to that hypercarbic respiratory failure, they can also suffer atelectasis, and they also have weakness of some of those oral pharyngeal muscles that control secretions. So they also are at higher risk of aspiration. And those two things together can actually put them at risk of hypoxic respiratory failure. And what I'm most interested in when I walk in the door with anyone with suspected, neuromuscular weakness is how well are they doing on gas exchange? And some of this is pretty easy to kind of just get a sense of at the bedside. Is the patient able to talk in complete sentences? Are they looking short of breath? If those two things, like the patient's talking to me and can give me a complete history of when their weakness started, I'm way, way, way less concerned that they're not able to maintain their ventilation versus a patient who can barely get out 1 or 2 words. Then beyond that, I think there are some sort of targeted things that we can look at the bedside. So we know that neck flexion can be a nice marker of diaphragmatic strength. So the patient who really can't even lift their head off the bed, that patient probably has pretty significant diaphragmatic weakness. The patient who can't count to 20 in a single breath probably doesn't have good inhalation or exhalation to maintain that ventilation. This gets better elucidated by actual respiratory mechanics. These are sort of portable spirometry that can be done at the bedside. Just to kind of introduce some of those terms, we talk a lot about the NIF, or the negative inspiratory force, which confusingly can also be called the maximal inspiratory pressure. So NIF is MIP, which is just, to make things complicated. We also talk a little bit about the maximal expiratory pressure, or the MEP, which is really kind of a nice marker of like how well the patient's able to cough. And then finally, we can measure how much air is the patient able to take in a forced vital capacity. Like when we ask them, how much air can you fill up all the way to the top, and then breathe it all the way out? How much air are you able to breathe all the way out after your maximal inhalation? So those are sort of the things. So again, that's forced vital capacity. Those are the 3 tests that very frequently we'll ask our respiratory therapists to help us objectively measure at the bedside. Just some numbers to keep in mind. This is again, like, you have to take the whole patient into consideration, but we know that patients who have a negative inspiratory force, that NIF, that falls below less than -30, those patients are not doing very well with gas exchange and have a higher rate of progressing to needing intubation. Similarly, patients who really can't take a forced vital capacity of 20 milliliters per kilogram of their ideal total body weight, which like ends up being somewhere around 1.5 liters, those patients again are also not doing a great job with gas exchange, and have the potential to progress to respiratory failure. The trick with all of this is that we really want to intervene and safely give these patients either support or intubation before they have any sort of blood gas abnormalities. Waiting for that PCO2 to rise, waiting for them to become hypoxic, that's really not the goal. We want to intervene before then with some sort of safe ventilation, depending on what the primary process actually is.
Great, excellent. That was really nice. Thanks for breaking it down, making it simple to understand. So let's say we talked about all of this and we took care of the respiratory status. What about all the other things? Let's talk about all the other neuro things that you're going to look for in these patients.
Right. So these are the patients we actually have to do a really comprehensive neuro exam to figure out why they are weak. Right. The most common reason that people come into the emergency department, to our neuro ICUs with weakness, is because of a central nervous system process. Here, we're really focused on the peripheral nervous system, meaning that there's a potential problem either within the nerve cell body, which is for motor neurons, the anterior horn cell, a problem with the nerves themselves, so a neuropathy, a problem with the neuromuscular junction, so one of those junction pathologies, or a problem with the muscle. And each of these is going to have sort of a signature based on our neurologic exam. To go through that comprehensively, I really invite people to look at the on-call chapter, but a couple sort of key bits to kind of keep in mind is that neuropathy pathology, so pathology of the nerve, tends to involve sensory, because the nerve has both motor and sensory components. So patients who do not have any sensory deficits and don't complain of any sensory pathology probably don't have a nerve pathology. They probably have either a neuromuscular junction problem, a muscle problem, or an anterior horn cell problem. Similarly, neuromuscular junction, we can think about presynaptic or postsynaptic. The most common of these is myasthenia gravis, which is a postsynaptic disorder. As such, it doesn't involve any smooth muscle cells. So the pupils are never involved. So I think that's a nice kind of pearl. And then muscle, people tend to have like muscular cramps or they have sort of muscle aches. And so, again, that's another way to, get a better history and try to figure out, where is this problem within the peripheral nervous system? Reflexes tend to be spared in neuromuscular junction problems and in muscle problems. Muscle problems, if they're very severe, you can lose the reflex, but lost reflex is also another way to point to a neuropathy problem. So again, you really are going to have to get out the reflex hammer. You're going to have to really assess, is there proximal involvement? Is it distal involvement? You're going to really need to build a comprehensive differential. But now, the most common two neurologic emergencies from a neuromuscular perspective are myasthenia gravis, which is a neuromuscular junction problem, and Guillain-Barre syndrome. Guillain-Barre syndrome is a catch-all syndromic name for a group of acute neuropathies that have a variety of presentations. So again, this is affecting the nerve root and the nerve itself. They have proximal and distal weakness, but the classic pattern is that it's ascending, that it starts in the toes, and they often have some sensory deficits, like a little bit of tingling, a little bit of back pain, and then it starts to get worse and starts to kind of almost creep up. Now, there are a lot of different variants of Guillain-Barre, so they don't all present like this, but that is sort of like the classic. So again, that's a neuropathy. Myasthenia, the hallmark of that disease is that it's a fatigable process. The neuromuscular junction, as you're asking it to exercise more, it becomes more pronounced, the weakness that the patient has. Some ways to look at that at the bedside are looking for ptosis, especially after sustained upgaze, diplopia, sort of weakness of the face, difficulty controlling saliva, and then that, again, fatigable component of weakness. These patients are a little bit difficult to assess with respiratory mechanics, quite often because they have facial weakness. That makes it really hard for them to form a seal, which is how we get these accurate numbers with spirometry. So again, you're using your neuromuscular exam to localize where the likely pathology is, knowing that many, many patients will kind of fall into one of those two categories. Please go check out the on-call textbook because there's a lot more detail within there about how to assess these patients. But one of the things that they all sort of share in common, or many of our acute neuromuscular emergencies share, is that they are inflammatory processes, which means that they require either induction immunosuppression if they've never been on immunosuppression, or an increase in immunosuppression if this is a chronic pathology that is well known. And so, Sally, I was hoping that you could kind of walk us through, very commonly we're using IVIG or plasma exchange. And there really are some nuances about when to choose what and what the contraindications and complications might be. So can you walk us through, like, how do you choose one and what should you be aware of?
Yeah, great. You're absolutely right. I think we talk about immunomodulation a lot when we talk about taking care of these patients and which route we're going to go. So I think for simplicity, we're going to keep it at IVIG and plasma exchange. Obviously, there's a whole lot of other newer options that we could talk about, but I think these two therapies or interventions are very much commonly done. I'm going to start with IVIG, and then we're going to kind of move to plasma exchange or Plex after that. I think IVIG is something that we've probably seen historically a lot more. One of the things that a lot of people are using this intervention for is that it is a lot less complicated. So let's say if you have a very old patient, someone without a central axis, someone that you just have a peripheral axis, and you know that you really can't push that any farther, IVIG may be a very reasonable choice. Again, these are all immunomodulatory. As we talked about, this is going to be neutralizing the antibody. This is going to be kind of suppressing that pro-inflammatory cascade that can be going on or may be going on. So a few things with IVIG. It can be prothrombotic, so that's something to keep in mind when you infuse that. I'm sure a lot of institutions have their own protocol as far as how to give it, the rate of administration, because the infusion-related reaction could be pretty significant if you give it fast. So, people have those hallmarks of shivering, Rikers, maybe a fever and things like that. So those are some of the things to think about. If someone has IgA deficiency, this could be an anaphylaxis, so just something to keep in mind. We commonly talk about that. But again, the nice thing about IVIG is that it can be given via peripheral line. This is probably something that may be also easier for someone who has a lot of medications on board, because when we talk about plasma exchange or PLEX, we talk about the fact that you need to think about drug removal also when it comes to PLEX, and I'll expand on that a little bit when we talk about PLEX. So that's really IVIG, and the dosing, we talk about 0.4 grams per kilograms over 5 days. So the total dose is 2 grams per kilogram. But guess what? We have to break this down over 5 days because you can't give that much drug. Now, moving on to plasma exchange, this one does require a central line. So is this something that is doable? Operationally, you do this on alternative days, and it's usually going to be 5 treatment options. So you're kind of dealing with this situation for 10 days. So again, it's a commitment. Now, what about drugs? So just like it sounds, any drug that has a higher tendency to stay in the plasma will possibly be removed by a plasma exchange. And what are those drugs? When you think about it pharmacokinetically, drugs that have a lower volume of distribution, meaning the drugs that are going to be staying in the plasma, and the drugs that have a higher protein binding, again, the drugs that will stay in the plasma, guess what? They're going to be removed probably higher. So again, if you have a really complicated case, right, you have someone who's on a lot of antibiotics, someone who's getting life-saving medications, PLEX may not be that safe, or you really have to think about looking at drug removal, talking to your clinical pharmacist, making sure this is the right, approach for them. Another thing that you see commonly with PLEX is mild degree of coagulopathy. So, if someone's getting anticoagulation at the same time, you may see your numbers kind of changing. I've seen elevated PTT in this setting. Again, remember that your coagulation cascade could be affected by this because of the coagulation cofactors and proteins could be affected by this. So that's just something that is expected and may be something that you want to think about before starting PLEX therapy. One last pearl about this is that you really don't want to PLEX someone after you give them IVIG, because PLEX will remove your IVIG. So this unfortunately happens in practice. My recommendation is that if you think your IVIG is not effective, have you given it enough time? You really want up to 2 weeks to see if your IVIG has been working enough. So another, again, pearl is that if you're in a rush, if this is something that you want to see, if you see the benefits sooner than later, maybe PLEX is something you want to do first, just because you commit someone to IVIG and then right after it's done, you PLEX them, you're going to get out all of that IVIG from the system, which obviously is not going to be efficient.
I think that's such an important pearl. I feel like we frequently see second doses of immunomodulating therapy given, whether that's IVIG and then more IVIG, or IVIG and then PLEX, which again, not a great idea, or PLEX and then IVIG. And at least within the Guillain-Barre population, there have been multiple trials that just didn't show a benefit of that. In fact, there's maybe even a signal of harm with more of these treatments. So again, pick one, stick with it, really give it for at least a month before you really have said, this did not work at all. The other thing that comes up so frequently, especially for our myasthenic patients, is that they have sensitivities to a lot of drugs, or there's a lot of concern that a drug might worsen their myasthenic crisis. So yeah, I know that list is like 50 drugs long, but are there common things that we see again and again in the ICU that we really do need to be mindful of with these myasthenic patients?
Yeah, I think this is such a good point, and you're right. I think when you look at the list, it's over 50 medications, and there's contraindications, and there's relative contraindications, and there's definite, and there's possible. So, um, I think for the sake of this conversation, I would limit it to what I think is absolutely necessary to know and what is absolutely necessary to think about. A lot of antibiotics are on that list, but I think there is three classes that I really think you have to be very cautious. Um, Aminoglycosides, that's one class. That's a very definite interaction. Your patients will be weaker. So if you can avoid that class altogether, that would be amazing. And that would be my recommendation. Luckily, there's a lot of other alternatives. So we don't see a lot of gentamicin or tobramycin or amikacin anymore. Another class is fluoroquinolones and then macrolides. So those three classes in in the antibiotic group, so aminoglycosides, macrolides, and fluoroquinolones, you want to avoid them. Magnesium supplementation is another, I think, big topic. Now, although it's a definite interaction, I think you have to keep an eye on the numbers and monitoring these patients closely. Obviously, if someone's magnesium is 1.1, right, and you have a cardiac patient, you have to provide enough supplementation and repletion so that your patient is not experiencing those side effects. But this is just to treat them, with more caution, to make sure that you're on top of their levels, to make sure that you're looking at that more closely than other patients. Another big class is neuromuscular blocking agents. I know a lot of institutions have actually very specific guidelines for rapid sequence intubation for these patients. The dosing is usually lower. We talk about how, you have to reverse these patients quickly. A lot of these people post OR actually come to a monitor setting very quickly, just because you want to monitor them, because you want to make sure that they're breathing fine and they're waking up okay and all that. Inhaled anesthetics, that's another class that, again, could be a problem, and you have to really watch these patients. And then one last class that I think is pretty controversial is corticosteroids. We do use corticosteroids for myasthenia, and absolutely that is part of the algorithm for treating these patients. But high dose corticosteroids can possibly exacerbate myasthenia initially. And that's why when you see high dose corticosteroids, you see IVIG with that, or you see that these patients are intubated during that time. And that's when we utilize that, because we want to give them that extra support so that they can get that extra support while they're on high dose, methylpred or other, corticosteroids, usually in an IV form initially with the high doses. But those would be my recommendations. The specific antibiotics we talked about, again, intubating with a lower dose of neuromuscular blocking agents, reversing them quickly, talked about magnesium, and then corticosteroids.
Those are really important, and they come up all the time, I feel like, in clinical practice. These patients are not patients that we see day in and day out, but they do come up frequently. And I think this has been such a fun way to kind of think back on how do you approach them with a conceptual framework? How do you make sure you're stabilizing them from a respiratory perspective? And then really, how do you be thoughtful about which immunosuppressant you're using and the other drugs that they may be exposed to in the neuro ICU? So with that, we'll actually wrap up. Any final words, Talia?
No, I think just having a neurointensivist to help you and a clinical pharmacist, and this podcast hopefully should get you ready for that.
I love it. This was a wonderful topic. So until next time, guys.